Welcome to Oncology Today, new datasets and their implications for breast cancer management. This is medical oncologist Dr. Neil Love. For this program, I met with Dr. Adrienne Waks from the Dana-Farber Cancer Institute in Boston. To begin, I asked Dr. Waks about her perspectives on the recent results of the PATINA trial of Palbociclib combined with anti-HER2 therapy and the potential integration of this treatment approach into the management of hormone receptor positive, HER2 positive metastatic breast cancer.
I think that the difference in PFS that this trial shows is just striking. You know, a 15-month delta in PFS is striking. So I can't think of a patient population in whom I wouldn't recommend the palbociclib, if they're not who's eligible from a toxicity standpoint. I just think the magnitude of benefit here was so impressive. I think in terms of the adjuvant patient population, that question comes up a lot and is a wonderful question. We know that in a patient who has early stage HER2 positive, ER positive and HER2 positive breast cancer, that we have lots of HER2 targeted agents that might reduce their risk if they look high risk. We have TDM1, we have neratinib, we have lots of ways of targeting HER2 for the patients who we think look particularly high risk in the adjuvant setting. What we don't know is if we can more optimally target other pathways and improve outcomes for those patients with what looks like higher risk early stage HER2 positive and ER positive disease. And we don't know whether adjuvant abema should be used in those patients. We tried to do, or there was an attempt to do a trial to answer that question, to randomize those high-risk ER-positive patients to standard therapy with or without abemaciclib. And to my knowledge, that trial just wasn't able to enroll because it's not a super common population. And so it didn't, we won't have the answer from that trial. I personally think that for a patient, especially one who you're particularly worried about, has multiple positive lymph nodes after neoadjuvant, chemo and HER2-directed therapy, or those patients where their HER2 status is somewhat borderline and you're more convinced biologically that they're ER-driven than HER2-driven, it's perfectly reasonable, I think, to offer that patient population adjuvant abemaciclib. But unfortunately, we won't have randomized data to demonstrate its benefit.
So I was mentioning to you that your colleague Hal Burstein was down here with us in Miami about a week ago for a program we did, and we were talking about PATINA, and he mentioned something I never heard of, which was that I guess Dennis Slayman a long time ago demonstrated that actually CDK inhibitors are even more effective in HER2, and I'm just kind of curious, I've always been curious in general about endocrine status and endocrine therapy in HER2 positive disease. You have neratinib where works better in ER positive. Any thoughts about the biology that's going on here?
I mean, I think it's clear that the ER pathway is super important in some HER2 positive breast cancers just in and of itself. And so it makes perfect sense that targeting it just as we would in HER2 negative breast cancer makes sense. In addition, and I think the neratinib data suggests this, there's potential, sort of biological crosstalk between those two pathways, the ER-driven, growth signaling and proliferation signaling, and the HER2-driven, proliferation signaling. There may be biological crosstalk between those two pathways where I agree, it may be not just that you need to treat ER because it's there and HER2 because it's there, but actually by treating one, you may favorably impact the other growth-related pathway. So I agree that I think that in clinical practice, how we harness that biology to manage these patients better is quite unclear. The neratinib data maybe suggests that use of neratinib in an ER-positive patient is a way to do that, but we don't, to my knowledge, really understand the biology of why that is.
So, ties into, we had a poster at the San Antonio meeting. We had several, but one was on choice of CDKI at first line setting. And of course, we saw a lot of ribo in general used. We're about to do another survey. These are of investigators looking at patients with comorbidities and other issues. I'm just kind of curious, is ribo your main choice unless there's some issue in the patient, or do you think that palbo is associated with less side effects, and do you use that in, for example, older patients, for example?
Yeah. So in general, I do use ribo as my first line agent of choice because of the OS benefit in the first line and second line setting. Obviously, abema has some OS data as well, but I do think that the diarrhea on average is harder to manage than the side effect profile of ribo. But I unequivocally agree with the statement that palbociclib of the three is on average the best tolerated. And, in terms of its PFS data, has exactly the same point estimate as ribo and abema. It's just in the OS data where we didn't see the same benefit. So yes, I do think palbo is the easiest to tolerate on average, although it certainly causes the most neutropenia numerically. And I do favor using it, and I still use it in the first line setting for a patient who I think will have particular tolerability concerns based on their age, or somebody who, tries abema or ribo and just says after a very short time, like, this is an absolute no-go for me. I've switched many of those patients to palbo with tolerability success.
I was thinking, of course, we didn't see that much choice of palbo unless we put, in this first survey we did, unless we put some comorbidity issues in there. But I'm realizing that now, doing the survey, now we're going to have people talking about palbo, HER2 positive, because PATINA was palbo, and also PIK3 positive, because the inavolisib trial used palbo. I guess the idea use a better tolerated CDK. So actually, with those two added in, there's even more palbo being used.
No, and I think it's an interesting point. I was really struck by, so Bill Kalin gave the plenary, one of the plenaries at San Antonio this past year, and just gave a broad talk about drug development. And one of the points that he was making is that, hitting multiple pathways in a cancer cell is usually a better approach than hitting this pathway and then you get progression, and then hitting this pathway and then you get progression, and on like that. And, it really struck me that palbo has been, because of its tolerability, has been successful now in 2 trials in that way. It's combinable with inavolisib and endocrine therapy. It's combinable with trastuzumab, pertuzumab, and endocrine therapy. And, I think it's really not clear that abema and ribo would be. I have no idea, but they are less well tolerated on average. So I think it's an important argument to keep in mind that, combinability and combination toxicity profiles is actually incredibly important and may offer a better way to treat patients if we can hit more pathways at once in a tolerable way.
So let's move on to, again, some of the themes that came out at your work. I think people can go through your talk for the details, but again, sort of themes. And another that you talked about in several of the papers relates to immunotherapy, particularly the Keynote 522 study with pembrolizumab, which, as you pointed out now, is showing a survival benefit. First, just kind of a broad overview of breast cancer and at least checkpoint inhibitors. It seems like triple negative is kind of where things are settling down. I'm curious what your thoughts are, again, of the biology of, why we don't see greater responses, what the key might be to get more out of immunotherapy. And I'm very interested in what you think about the NSABP B59 study that uses Atezo that didn't find the same thing as in pembro.
Right. So yes, I think we have seen over and over again now in metastatic ER-positive disease anyway, checkpoint inhibitors fail where they've have a FDA approval in metastatic triple-negative disease. In terms of, I think, a very important question in terms of number of patients it affects is, well, how can we get immunotherapy to work better in ER-positive disease, both early stage and later stage? I was hopeful that maybe combining immunotherapy with an antibody-drug conjugate might be better than just standard chemotherapy because of all the sort of immune mechanisms that go along with antibody-based therapy that maybe don't with standard chemotherapy. I think, unfortunately, that hasn't worked out yet. We saw presented last year the randomized trial that our group did of sacituzumab plus or minus pembro in metastatic ER-positive disease, and it was a negative trial. And so I think that was disappointing. I think we're still looking, maybe there was a signal that if you had high PD-L1, which wasn't very common, maybe the pembro did add. But the short answer to your question of how do we combine immunotherapy, or how do we use immunotherapy to our patients' benefit in ER-positive metastatic breast cancer anyway, is that I don't know. And I was hopeful about ADCs, and I don't think that's worked out so far. We'll see that also studied in that the TroFuse study, where it's sac-TMT plus or minus pembro in a randomized phase 3 trial. So those will be more definitive data than the sacituzumab plus or minus pembro phase 2 data. That will be interesting. I think it's still a really important question, but so far the results have been disappointing. Obviously, in early stage ER-positive disease, we saw the results presented of the Checkmate 7FL and the Keynote 756 data, where if you look at essentially high-risk grade 3 ER-positive early breast cancer and you give them neoadjuvant chemo plus or minus pembro, you do see a PCR benefit for the addition of the pembro. And so, maybe there's some promise there about immunotherapy working in earlier stage ER-positive disease where, the host immunity is generally more intact. But I also think that PCR is not a meaningful endpoint in early stage ER-positive disease. And so we really have to wait and see how those EFS data pan out before we know if immunotherapy might work better in the early stage setting than it has in the later stage setting for ER-positive disease. There was a second aspect of your question, and I forget it now.
Yeah, it was about atezolizumab, where, I feel like there are a couple others. Yeah, I think there's a couple other studies outside of breast cancer where, again, atezo, I can't remember if it was lung or bladder, I think that maybe didn't work as well as, I think it was pembro. Any thoughts? Do you think it's the intrinsic activity of the agent, or could it be the way the trial was done?
My personal suspicion is that it's the intrinsic activity of the agent, and whether it's sort of drug specific or just has to do with targeting PD-L1 as opposed to PD-1, I truly don't know. But I think as you say, in trial after trial in breast cancer, and potentially even beyond breast cancer, although I only study breast cancer, it's just an agent that has looked less effective than pembrolizumab. We saw that in metastatic triple-negative breast cancer as well, where the confirmatory trials of atezolizumab failed for metastatic triple-negative breast cancer, and ultimately the FDA approval was withdrawn on that basis. So yes, I think atezolizumab has not met its primary endpoint in multiple populations where pembrolizumab did, and I tend to suspect that that's a drug or target PD-L1 versus PD-1 issue.
So sorry to keep quoting your colleague, Dr. Burstein, but he has a tendency to say things that I want to hear more about. And
he's said something on quotable guy, yeah.
So he said something, I don't remember anybody saying this, and I was just really curious whether it reflects your viewpoint. And I was noticing when you were presenting the updated 522 data that I think you said it was like 13% grade 3 autoimmune. And he was saying, wow, this 522 is a very difficult regimen to give. And he was citing examples of all kinds of autoimmune issues he'd seen in patients. Is that your experience? And do you think it's more, autoimmune toxicity than, in other settings, metastatic disease, for example?
I do think that it's a hard regimen. My impression, in fact, when I give it to patients in the neoadjuvant setting, I usually either at the outset or as sort of a pep talk somewhere along the way, tell them, by the way, I think this is the hardest regimen that we give in terms of tolerability in any early stage breast cancer. And so I do agree that it has significant short-term toxicity. I think in my experience, actually, a lot of that is driven by the platinum and the additional chemotherapy. It's it's a lot of cytopenias and treatment delays for cytopenias and mouth sores, and additional growth factors and romiplistim and things like that. So my personal impression is that a lot of the added tox is actually chemo driven, not IO driven. But absolutely, the fact that there's the potential for these immune-related toxicities that we also have to be worrying about and working up for. It's no small thing necessarily to be starting 15% of our patients on thyroid replacement, which we're generally doing at some point over the course of this regimen, and that's something they have to, just deal with in addition to everything else. So I think it's the whole thing together for sure, but I actually think it's a lot of chemo side effects that make a big difference here.
So I guess I'm going to have to quote another one of your colleagues, Dr. Tolaney. And one of the things that when I was working with her not too long ago that came up, I saw a paper she did that really kind of raised my interest in the issue of ER low. We talk a lot about HER2 low, but I saw this paper that she was part of, and I was starting to think about it. And, these patients who are ER, 0 to 10, now, it's very different if they're truly triple negative. They're going to get the 522 regimen as opposed to an ER positive approach. How do you decide what to do in those patients?
Yeah, I think there are more and more and more data that an ER low patient, so 1 to 10% expression, PR negative, should be managed as triple negative. And that's unequivocally actually what I would do in a patient like that. I would give that patient the Keynote 522 regimen, and I tell them that, biologically they are triple negative. I think, we have increasing data sets that tell us that the PCR rates for an ER low patient are more equivalent to what they are in a triple negative patient. That was looked at in the quote unquote ER positive neoadjuvant trials, the Keynote 756 and the Checkmate 7FL. The PCR rates in the pembro containing arms on those trials was basically the same as what we saw in Keynote 522. We've seen that in some of our own cohorts that we've studied. And by the way, I think the same is absolutely true in HER2 positive disease, that if you have HER2 positive disease and you're ER 1 to 10%, you're going to behave like, and your sort of clinical risk should be considered as a patient with ER negative HER2 positive disease. I think where it does get hard, so that would be my answer. I would manage them as ER negative completely. I do think it gets hard then in sort of a higher risk situation when you try to decide, should I give endocrine therapy? After everything else is said and done, I've managed them as essentially triple negative, and now I'm trying to decide because on 1 or 2 biopsies they were ER 10% or they were ER 5%. Well, how do I now present the possibility that they could benefit from 5 years of endocrine therapy? I find that a really difficult discussion to have with these patients. You cannot completely rule out some small benefit of endocrine therapy. There was that analysis, I think was at ASCO 2024, where the Mayo group tried to look at whether there was benefit of endocrine therapy in those ER low patients. And what they maybe showed, with the caveats of like a retrospective and non-randomized analysis, was that if you didn't have a PCR, you maybe did benefit from adjuvant endocrine therapy. It sort of implied to me that if you select a particularly high-risk group among the ER lows, that just because their risk is higher, like they didn't have a PCR to neoadjuvant chemo, for example, or they had stage 3 disease or something like that, maybe you get a tiny, tiny benefit from the adjuvant endocrine therapy. I think we don't know. But I think that's a really tough discussion. But I would manage them as triple negative for all other purposes.
So, I guess it's the decision we always have, but it just got a little bit more complicated once 522 came in. But I guess once you get through the chemotherapy, immunotherapy, you're back to whether or not, I guess it feels a little weird to give endocrine therapy when you just give the 522 regimen, but sort of it does really make sense. I want to bring up another topic that you talked about. You brought up data that was presented updating the Olympia study. And I was just kind of curious about that. I'm kind of curious, how many people have you treated with adjuvant olaparib, roughly?
Probably about 5, not that many.
That's what I'm going to say. When I ask investigators of a high volume of patients, they always say, very few patients. I was kind of expecting it was going to be more. We just did a really interesting webinar with Mark Robeson and Kevin Hughes on BRCA testing. And I'm wondering, first of all, do you think we could be missing people? Because when we started looking at the guidelines, there's everything from NCCN, where everybody, particularly in terms of age, family history, Ashkenazi, that's another story. But just
Yeah.
based on age, triple negative, et cetera, but more typical ER positive, HER2 negative, just based on age. You have the NCCN saying under age 50. You have ASCO saying under 65, and you have the American Society of Breast Surgeons saying everybody.
Everyone.
So first of all, I'm curious what you think the right answer is, and do you think we're missing people?
I think we miss a huge number of people. And, I am in favor personally of trying to set up mechanisms in clinics where we do offer genetic testing to basically everybody with breast cancer, because I still think even with those mechanisms in place, we still miss people. Patients don't understand why they're being asked to do that. It doesn't get into our sort of initial consult conversation, and then patients decline, and then it never really gets brought up again. And so I think that we miss a lot of people in the early stage setting. I think we miss even more people in the metastatic setting, where it changes therapy for any HER2 negative patient. And I can say, personally, my own experience in clinic is that it's something that patients, I think, have misunderstandings about the importance of and resistance to. And it's, as a provider, I might forget to bring it up or not bring it up in the right way. So I think that we miss a lot of people, and that if there were processes in place that just made it more universal and sort of took it out of a provider-patient conversation and made it part of the workflow of the clinic, that would be helpful, because we'd hopefully capture more people, and it really can have treatment implications for so many.
Another thing that you presented that I thought was really interesting, I haven't seen it, maybe it was out there before, was second primaries. So breast,
Right.
I can kind of understand, although I'm not sure I've seen that before, but also pancreas and ovary. Like, how solid are these data? Is this really for real? And what do you think it means?
The data are not super solid. The actual numbers are like 7 pancreas cancers in the control group and 4 in the olaparib group, or something like that, or 3 and 1, something like that. So these are not definitive prevention data by any means. But I just think it makes so much sense, and the data numerically in the small numbers that we have are consistent with the idea that we potentially do prevent additional primary BRCA-associated cancers, breast, pancreas, ovary. But are the data definitive? Definitely not. The numbers are small.
Well, interesting. And then another thing I'm just curious about is what type of genomic abnormalities get you to want to use adjuvant olaparib? I'm not sure exactly who you can get it for beyond BRCA. So PALB2 is an obvious one,
Right.
somatic versus germline, BRCA, and then everything else.
Right. Yeah, that was one other thing I did want to mention. So, for me, in the early stage setting, when we're using olaparib considering it in the adjuvant setting, I absolutely think that PALB2 germline carriers should be considered along exactly the same lines as the BRCA1 and 2 mutation carriers. So if a patient met criteria for the Olympia trial but had a PALB2 germline mutation and not a BRCA1 or 2 mutation, I would offer that patient adjuvant olaparib just as if she had or he had a BRCA2 mutation. That, for me, is based on the very compelling data from Nadine Tung's olaparib expanded trial in the metastatic setting, showing that PALB2 germline mutation carriers had a very high overall response rate and clinical benefit from olaparib in the metastatic setting. We have no such data in the adjuvant setting, but I just think the metastatic data are so convincing that I would use adjuvant olaparib in a PALB2 mutation carrier. I have never actually had that come up in my practice, and so I have never had to find out if an insurance company would approve it. I have had it come up in my practice in the metastatic setting, that I've had PALB2 mutation carriers who I felt were should receive olaparib in a palliative setting based on the olaparib expanded trial data. And I have found that insurance coverage is inconsistent. I have not universally been told yes in that setting for insurance coverage for a PALB2 germline mutation carrier. So with respect to the somatic BRCA1 or 2, or for that matter, PALB2 gene carriers or somatic mutation carriers in their tumor. So we don't do, as you know, the genomic testing in early stage disease. At least I can't think of a time we ever would. So we would never, to my knowledge and my practice, know in an early stage patient if somebody had a somatic BRCA1, 2, PALB2 mutation, because we don't do that sort of somatic sequencing in the early stage. So there I don't apply those data because I wouldn't know. In the metastatic setting, however, my answer resoundingly is yes, again, based on the olaparib expanded data from Nadine Tung. With a somatic BRCA1 or 2 mutation, I would absolutely offer that patient olaparib. And in fact, that's one of the main mutations I'm looking for when I'm doing ctDNA, over and over in a later line setting, or I'm doing, a biopsy after a 4th or 5th line therapy or something. That is one of the alterations that if I found it, which I would only very rarely, but if I found it, would be targetable for me and actionable for me, sort of along the lines of an ERBB2 mutation, for example.
So that leads into a broad topic or question I wanted to ask you that relates not only to PARP, but also a couple of other things that you were talking about, particularly the use of doxorubicin, which is the idea that, at least the traditional idea that I think has been out there in the adjuvant setting that kind of came out of the overviews that were done by Oxford, which is this idea, and of course that was obviously done with, chemo and tamoxifen, et cetera. The idea that once you establish a hazard rate, that supposedly it applies regardless of what the absolute risk is.
Right.
So if you want to calculate the absolute benefit of a therapy, you take the hazard rate, you integrate that into what the absolute risk is, and you come up with the absolute benefit. Then you look at the toxicity of the treatment and decide whether it's worth it. So in this case, olaparib's not, Tylenol, but it's oral, relatively well tolerated. I think the fact that, we're not really seeing much of a signal or no signal at this point for AML and MDS is really great. And I see this in a number of situations. The same thing kind of applies to the bar for using CDK adjuvantly, and we'll get into this issue of doxorubicin. But a lot of people, we've done, studies of patients, and they're quite variable in terms of how much they're willing to do for minimal benefit. The classic studies on chemotherapy and breast cancer said that some patients are willing to take chemo for a very minimal benefit. So I guess my question is, it seems like, on the other hand now, like with olaparib, you take the Olympia criteria and apply those. And my question is, why can't you go down lower? Putting aside reimbursement.
And I think you could. I agree with everything you said, by the way, about sort of relative benefit being consistent across all breast cancer therapies in all populations, and then you have to sort of figure out absolute benefit based on the patient's, initial risk profile. I agree with you. I think olaparib is a relatively tolerable therapy. It's not side effect free. I think 5 years ago and 8 years ago, we were pretty worried. And I remember having some conversations with patients taking olaparib about, I want you to know, if you Google this agent, there's an association with MDS AML, and we're using it in an early stage setting, and I want you to be aware of this. I think the Olympia data have been really reassuring for helping us know that we don't need to dwell too much on that for this curative intent patient population. So yes, on balance, I would potentially use olaparib for a lower risk patient than who was, enrolled in the Olympia trial. Especially I think like in the hormone receptor positive patient population, you had to get this really high risk profile and really enormous amount of residual disease. I don't, in my practice, do that calculator and say you have to check all these boxes in order to qualify for it. Another area where I have used olaparib and I've gotten insurance approval, and certainly not in the standard FDA label, is in local regionally recurrent disease for a BRCA1 or 2 carrier. I've had a couple of patients actually who have had low risk, but nonetheless recurrent disease, local regionally recurrent disease after completing treatment for an early stage ER-positive breast cancer. And I've used olaparib as adjuvant therapy for a local regionally recurrent tumor, because I think even in that case, if a local regional recurrence happens on or after adjuvant endocrine therapy, even if it's 2 millimeters or 5 millimeters, you're much higher risk to me than if that was your initial presentation. And I have used adjuvant olaparib in that setting. Just like similarly in a non-BRCA mutant patient, I would use an adjuvant a CDK4/6 inhibitor in that setting because it's higher risk to me because of the local regional recurrence.
That's a really great point. I wish we'd put that in our survey. Next time we do it, I'm going to include that scenario as well. We always like to see what people are doing. Can you talk a little bit about sort of where we've been with the use of doxorubicin in general with breast cancer, particularly in the adjuvant setting, and even more so in the ER-positive setting, and how that's changed, if it has changed in your mind, since the more recent data looking at high-risk patients? You talked about the data looking at R-exponder. There was a previous study done by Julius O'Shaughnessy, who was also there last Saturday with us as well, using mammaprint. So can you kind of summarize where we've been and where you think we are right now in terms of anthracyclines?
Right. So, I think it's a hot clinical question, and it comes up all the time, especially like you said in ER-positive breast cancer. I think in HER2-positive breast cancer, to quickly address that, it's basically fallen out of favor because there's been such good data that TCHP is an adequate chemo backbone. And so there's very few patients where anthracycline gets used in HER2-positive breast cancer at this point. I think in triple-negative breast cancer, it's been considered to some extent answered in the other direction, meaning triple negative, is high enough risk that if you're getting chemotherapy and there's anything worrisome about that patient, aside from like a super low risk, adjuvant patient with stage 1 disease or something like that, you're going to incorporate an anthracycline. So I think those two subgroups have, there's certainly still questions to debate, but a lot of them have been answered. It's really in the ER-positive patients where this question comes up over and over again. Obviously, we worry about the anthracyclines more so than we worry about pretty much any other agent that we're using because of the late risk of cardiotoxicity and leukemia. And, there's something so reassuring about other chemo agents that we give, where at least we can reassure our patients and say, I'm going to know if this is happening to you, and I'm going to be able to modify accordingly for this toxicity. And that's not the case when you're obviously worrying about cardiomyopathy or leukemia happening 2 or 5 or 15 years down the line. So I think the trepidation around anthracyclines is well founded for that reason. And I think more and more we've seen data from, for example, the ABC trials that tried to look at this question of anthracycline containing regimens versus non-anthracycline containing regimens, and did look like in the overall population there was benefit to the anthracycline. But if you broke out a lower risk population, like the hormone receptor positive patients, the node negative patients, that maybe the anthracycline wasn't worthwhile and wasn't actually benefiting you. We saw the same thing in I think it was a German trial that looked at 6 cycles of TC versus ACT, more or less, and showed that the 6 cycles of TC were basically equivalent. So, I think from those 2 trials, the German trial, the ABC trial, I've become increasingly skeptical that anthracycline is something that we need if you're able to pick out a lower risk ER-positive patient. But then, of course, the question is, okay, but how do I pick out my lower risk ER-positive patient? Because I think we're all convinced that even for an ER-positive patient, if they have enough risk, then the anthracycline does add something. And so, the biomarker data that's been looked at in this regard is all not completely definitive because it's sort of retrospective and comes with limitations, but certainly is helpful because in clinical practice, I think we're just grasping for something that seems reasonably helpful. So, I think the MammaPrint High 2 data or the MammaPrint High data presented by Joyce O'Shaughnessy is helpful and interesting, although in clinical practice, we don't check that genomic risk score in the US in widespread ER-positive patients necessarily. Certainly, we don't check MammaPrint super routinely at Dana-Farber. We more commonly check the Oncotype 21 gene recurrence score. But, I think that the Oncotype data that we just saw come out of San Antonio, where those patients with the recurrence score greater than or equal to 31 did seem like they potentially particularly benefit from the anthracycline, ring true with those MammaPrint data and also with the anatomic risk data that we've seen, and sort of validate this idea that if you define a patient's initial risk profile, whether it be their anatomic disease burden, they have a lot of lymph nodes, they're N2, they're N3, whatever, or it be their biological profile, they have a super high 21 gene recurrence score, they have a really ugly looking MammaPrint score. Either way that you want to define who's at higher risk at the outset, those are patients who will potentially benefit from the anthracycline. So I think those data ring true and sort of resonate with what we've wanted to do in clinical practice anyway, and has now been, a bit validated by those biomarker data.
So I actually went to one of the overview meetings in Oxford once a million years ago, and I remember one of the things that Richard Pito said that I never forgot was, lack of evidence of benefit is not necessarily evidence of a lack of benefit. And I'm getting back to this hazard rate thing because, it's one thing to say clinically it's not worth giving to a patient, but if you believe in this hazard rate thing, you could say, well, in the lower risk patients, maybe there is a benefit, but you don't have enough events or patients to see it. So I think I saw that in that Oncotype data, the hazard rate was like 0.32. Is that kind of generally what's thought to be a benefit compared to non-anthracyclines? It seemed pretty high or low, depending on how you look at it. And, is it, again, just the issue that, when you, I don't know if there's how
it was, I'm looking at it now. It was 0.32. You're absolutely right. Yep.
I mean, that's a pretty good hazard rate there. And, I think that number I think it would motivate a doctor a lot, I think, in a high-risk patient. And another way to look at the low-risk people is maybe the benefits there, just very little, it's not worth the toxicity, et cetera, But I think that struck me, that 0.32. That's a pretty significant benefit. So I guess it'll be interesting to see how people respond.
I agree. I think it's a very favorable hazard ratio, yeah. It's just that if that doesn't translate into a high absolute benefit, then maybe it's not worth the long-term toxicity. But yeah.
Yeah, but you have a high-risk patient and a good hazard rate like that. That's pretty solid. People do not like. People do not like doxorubicin though in general. So I feel like a lot of people really need some motivation, and maybe that's worth considering. One other thing I just wanted to bring up again, your colleague brought this up, Hal brought this up on Saturday when we were talking about this doxorubicin data. He said, quote, there are a couple other issues out there about genomic evaluation and particularly Oncotype that he feels are really important to be looking at and thinking about. One that he brought up was greater than 4 positive nodes, well, greater than 3 positive nodes, I should say.
Yep.
The old story about does the biology really change when you go from 3 to 4? I'm kind of curious, I don't know if we'll ever see a study, but do you bring up the possibility of holding off on chemotherapy in a patient with 4 or 5 nodes if they have low recurrence score?
To my knowledge, there will be at least 2 trials that do try to get at that. I think one in Europe and one in the US. Yes, and they'll compare, I believe, chemo to just a CDK4/6 inhibitor based regimen for those 4 positive lymph nodes and beyond. So I think the question will be, how fast do those trials accrue? Potentially very slowly could be the answer. And so, how long are we waiting for some definitive data? But I do think we'll get some data in a long time to help us with that. I absolutely talk about that in clinic with, select patients who have 4 or more positive lymph nodes. I would basically kick out at the outset any premenopausal patient from that discussion, just based on how questionable the RX bonder data already are for 1 to 3 positive lymph nodes in a premenopausal patient. So I would pretty much not bring that up in a premenopausal patient. But I think for a postmenopausal patient, especially one who's, older, especially one where you're worried more about the toxicities of chemotherapy, both short and long term, especially one who just looks particularly not chemosensitive biologically, they're lobular, their oncotype is 3, things like that. I absolutely, talk about it in some cases and think it's a very reasonable approach to omit chemo personally after a risk-benefit discussion.
Another thing he brought up is the issue of lobular cancer and interpreting recurrent store data in those patients. Any thoughts?
To my knowledge, we can interpret the recurrence. I use the recurrence scores in the same way. I expect them on average to be lower, and I expect chemo benefit. There's plenty of data suggesting that chemo benefit overall is lower in lobular ER-positive patients. But I take recurrence scores, at their same face value in an ER-positive lobular population.
So last general topic I wanted to bring up that you went through. We always talk about it, seems like no matter what cancer, is ADCs. There are a couple of new ones that you talked about. Patritumab deruxtecan, an agent that we've heard about in lung cancer as well, HER3 antibody-drug conjugate, and I guess sac-TMT, another TROP2 agent. We already, as you mentioned, have Dato-DXd approved on the table. TDXD, obviously, in HER2 low, and sacituzumab. So can you just sort of capsulize your view of the 2 at least newer ones on the block? And then you can maybe get into, if we have all these available, how are we going to use them? But patritumab looks like a pretty favorable tolerability and efficacy issue. It seems like maybe less ILD, or I don't know, is it less nausea and vomiting also than, say, TDXD?
I think it was a bit less nausea vomiting. Yes, it was a bit less, about half the amount of ILD, and the ILD was low grade. So I think the tox looks favorable. It looks, really tolerable. And I think the efficacy data looks exciting in the, phase 2 cohorts that we've seen so far. I think the same thing for sac-TMT, efficacy-wise, I'm convinced we have a randomized phase 3 trial in sort of a similar population to the ASCENT trial in pretreated metastatic triple-negative breast cancer, where this agent, the sac-TMT, is performing better than chemo. So I'm convinced by those data that it's an active agent. I think the real problem is, I don't have any questions about that. The enormous problem that we're going to have is that, yes, some of these agents have different targets. There's TROP2, there's HER2, now there's HER3. I'm also convinced that more and more, it doesn't really matter how much of any of those you have on your cell surface. These are all better than standard chemo. But at the end of the day, so many of them have the exact same payload. Multiple of these are using DXd, Dato, trastuzumab deruxtecan, and patritumab deruxtecan have the literally exact same payload. And then even if they don't have the exact same payload, sacituzumab govitecan and sacituzumab tiromatican both have a topoisomerase 1 inhibitor payload still. So, there's a lot of mechanisms about these ADCs that are incredibly overlapping. And while I'm completely convinced that in their own right, they are each better than a standard chemotherapy, I think the real question, and to my knowledge, there's very minimal evidence at this point to help guide us in this. The real question is going to be, which one is the best? How do we compare them to each other and figure out which one is the best? And then, how is there any value to sequencing them, and how do we figure out how to do that? And so I think that's where we've got to go. I'm convinced they're active agents, fine. But the potential for cross-resistance and figuring out which is better than the other, to me is absolutely completely unanswered.
So, also is the question of measuring the amount of target. Obviously, with HER2, you were talking about TDXD. It looks like there's some correlation there. We haven't really seen that with TROP2. There was an assay, some kind of membrane assay for TROP2 reported at the World Lung Meeting, because where they studied, I think it was Dato, that looked like the amount in that particular TROP2 assay might have been correlated. Where do you think that's heading? You think we're ever going to get to a day where we're going to be able to measure TROP2 and decide based on that?
Well, I think the thing is that for limiting just to TROP2 initially, and the sacituzumab govitecan data, like the Ascent trial data, and then the TROPiCS-02 data, so the hormone receptor positive, HER2 negative data for the same agent. I think that the data do suggest that your PFS is likely to be longer with the TROP2 targeted agent if you have more TROP2 on your cell surface. So and that I think was definitely the case in TROPiCS-02. If you had more TROP2, there was at least a trend toward your PFS being longer. But in any subgroup, even the patients who had super low levels, undetectable TROP2, the sacituzumab was still better than the standard chemotherapy. And that was true across all subgroups. So I would still use the quote unquote targeted agent that's maybe not so targeted and think it would do better than eribulin, capecitabine, paclitaxel in any patient. So I don't need to know, the TROP2 level to make that decision. But, maybe there is a suggestion that how much you have dictates how well you'll do with the agent. And so maybe we could get to a place where we actually can quantify how much TROP2 is there and use that to help make a decision between a TROP2 targeted agent or a HER2 targeted agent, for example. I don't think it helps us make a decision between a TROP2 targeted agent and a standard chemotherapy, though.
Constantly oncology, we have this issue of indirect comparisons. And again, we got Dato and TDXD already out there, and then you have these other two. So any sense in terms of efficacy, for example, Dato versus TDXD? I mean, a lot of people have seen patients respond really well to TDXD, HER2 low, et cetera. But, is it your sense that, for example, TDXD has more anti-tumor effect than Dato?
Yes. My short answer to that is yes. I think the totality of the data, and we do have more data obviously with TDXD than Dato-DXD so far, but the totality of the data for me are more impressive for TDXD than for Dato-DXD in terms of its efficacy. The population where we can best compare that is hormone receptor positive, HER2 negative metastatic breast cancer, where we can compare the results of the DESTINY-Breast04 trial, which was TDXD in a second line or so chemo population, versus the results of the TROPION-Breast01 trial, which is Dato-DXD in a similar population. And you're absolutely right that cross-trial comparisons come with issues, but just in terms of the performance of the PFS performance of the regimens, the TDXD versus the Dato-DXD, the median PFS of the TDXD was just over 10 months. I think it was 10.1 months maybe in DESTINY-Breast04. And in the TROPION-Breast01 trial, it was, I believe, 6.9 months. So yes, that's a cross-trial comparison and comes with a lot of issues. But I do think that TDXD looks at this point potentially more active than Dato-DXD. Not to mention that TDXD is associated with an OS benefit, and Dato has never shown that.
This issue came up the other day in a webinar we're doing on biliary tract cancer, where you have TDXD and zanidatamab. And, we're talking about, okay, which one's going to come first? And, the idea that it looks, zanidatamab doesn't have ILD, and that potential threat. And particularly once you get outside of breast cancer, people are really worried about ILD even more. Is that the way you think people, or is that the way you look, for example, right now at Dato versus TDXD and HER2 low ER positive? In other words, if you have a patient who doesn't have very aggressive disease, would you go to Dato first because I guess Dato could have ILD, but maybe not as great a threat? Or would you go to TDXD because even if it was lower volume disease, just because it works better?
Yeah, I mean, I would go with TDXD over Dato-DXD completely 100% of the time. TDI, there is still a pneumonitis concern with Dato-DXD, but it is lower than with TDXD. So the rate of ILD in the TROPION-Breast01 trial was 4 or 5%, and there was one grade 5 event. Obviously, with TDXD, we see it at 12 to 15%, and I've seen about a 1% rate of grade 5 events. So the pneumonitis concern is legitimate. That is less with Dato-DXD. But I just think the efficacy data is so much more compelling for TDXD, and especially that OS benefit.
So another impossible question. HER2-0, you have Dato, sac-TMT, and patritumab available. Any thoughts about which one of those would come first?
Dato, sac-TMT, and patritumab. I mean, at this point, in a hormone receptor positive patient, at this point, we don't have any data for sac-TMT in that population at all. Or any, definitive data like from a phase 3 trial at all. And Dato has evidence from a randomized phase 3 trial, but I think the patritumab, honestly, at this point in its development, looks extremely exciting, and from a toxicity perspective, potentially even better than the Dato-DXD. So I'm going to sort of leap forward and say, well, assume that patritumab ended up with randomized phase 3 data just like Dato has, then, I think potentially from what we've seen so far for tolerability reasons, that patritumab could be the more compelling of those agents. But I think it's a little hard to say, with earlier data from patritumab.
One other final thing I wanted to ask you about, getting back to one of the papers you presented, I think it was the PADMA trial, that was chemo versus endocrine therapy. I was just kind of curious whether the strategy of chemotherapy induction followed by endocrine therapy maintenance has been tested compared to endocrine therapy alone, and whether that's a strategy that you use, for example, on really sick patients.
It's by and large not a strategy that I use in really sick patients. No, I'm sufficiently convinced by the PADMA trial, the Right Choice trial, the Young Pearl trial. And by the way, the control arm of PADMA, they did allow, I think it was per investigator discretion, you could do just chemo induction and then endocrine therapy maintenance. So that was part of the comparison. What proportion of their patients got that versus just got, paclitaxel and continued indefinitely, I don't know. But so that maintenance, that question about a maintenance endocrine therapy was at least part of that PADMA trial. I think for me, what's been hard, because this has come up for me a few times in clinic where I've had a patient with a newly diagnosed metastatic breast cancer that just extensively involves the GI tract, extensively, and where I just could not feel confident that they could absorb oral therapy, or they tried and they just couldn't take it and they're vomiting. And, so I've had actually recently 2 patients like that, where for various reasons, I tried to give them an initial CDK4/6 inhibitor-based regimen and it just didn't work. And I switched them to TDXD in that case, because they can't take capecitabine because they can't take oral therapy. And in both of those cases, that's been wildly successful. They did much better with the IV than the oral agent. I think that that's about absorption and tolerability of being able to take a pill, not necessarily about the relative efficacy of the 2 agents if they were actually in your bloodstream. But in both of those cases, then you're left a few months in saying, well, should I now take them off their IV, their TDXD and switch them back to endocrine therapy? Because that's sort of what I wanted to do in the first place. But I think it's really hard to do that in clinical practice, because once they're used to something like TDXD and they're tolerating it well, generally, I don't want to take somebody off a therapy they're benefiting from. So that for me has come up in terms of like not doing an endocrine therapy maintenance strategy in these really, really select patients where I've had to start with an IV agent. But if there were a tolerability reason to try to switch back to something like endocrine therapy and CDK4/6, I definitely would.
This concludes our program. Special thanks to Dr. Waks, and thank you for listening. This is Dr. Neil Love for new data sets and their implications for breast cancer management.